نعم دكتور.
Okay. Okay. So we discussed previously the steps of managing a patient or multiple trauma patient in an emergency department in the form of a primary and secondary survey. Before that, we should make a preparation as a review of our last lecture. We will make a preparation status. The preparation could be in a pre-hospital phase and in hospital phase. Pre-hospital phase, that's happened when you get an announcement of a mass casualty was happened. So you should classify the things that you need preparation. So you should have a first aid instruments and tools regarding the gauze, the bandages, and the fluid, and the minor operation set, and also the personnel of your help, that the nurses, and also the personnel of the transfer, and the personnel on the laboratory, and even the imaging center personnel like a CT and X-ray and a FAST. Then when you receive a patient, you should summon and build new modalities of receiving patients parts, like groups, that you should put the patients in these groups. And first of all, you should classify and triage the patients according to their severity. Then you should have a triaging, either a simple triage or an advanced triage. And the simple triage is when you have patients within the capacity of the receiving facility. So when you have a hospital receiving patient and it can cope with, you should make a simple triage. Simple triage means that you put the serious patient in the first. While if we have an advanced triage, an area that when the number of patients exceed the capability of that hospital, so we will do an advanced triage of managing the patient with the less severity in the first. It is not accepted in certain people or in certain protocols, but it is should be done when you are living in a peripheral hospital and you receive a lot of patients. يعني عندنا two types of triage. We call it simple triage or advanced triage. السمبل triage يعني من أنا عندي مستشفى عملاقة أو مركز إصابات، وأنا اجيت استقبلت المرضى وكان ضمن إمكانيتي بهالحالة راح أقدر أعالج المرضى اللي تكون إصاباتهم أشد بالبداية، يعني اللي يكون مالتهم الليبلينج أحمر أو أصفر بالبداية، لأنه أنا أقدر أعالجهم، عندي بيرسونيل، عندي فاسيلتيز، عندي equipment، عندي تولز. بينما إذا أنا قاعد في مركز مستشفى بالقضاء أو مركز صحي وصار بصفي حادث كبير، فأنا راح أشتغل بالعكس، اللي إصاباتهم أخف هم اللي راح أنا أعالجهم بالبداية. ليش؟ لأن هم اللي راح يأخذون من عندي وقت أقل، وأقدر أحصل على عدد أكبر من المرضى المتعافين بنفس الوقت. وبعدين أجي على الإصابات الشديدة، لأن هي اللي راح تأخذ الوقت الأطول، وأنا لا عندي بيرسونيل ولا عندي فاسيلتيز اللي تساعدني بالمانجنج. So after triaging, we will have a primary survey and its adjuncts, as we know, with the resuscitation. Then after that, re-evaluation, and we should come back to the secondary survey. Now we'll have notes about what is secondary survey and its adjunct, what the meaning by its adjunct, and then re-evaluation. After that, we have the major two ways. We choose one of them, either refer of a patient to the specialist hospital or definitive treatment. The most important question is when I start the secondary survey. The answer is after completing the primary survey and your patient is stable. What do we mean? When I have a primary survey of my patient, I'm checking the airway, breathing, circulatory status, and patient is good, then I will go to the secondary survey, looking for facial maxillary fractures, chest injuries, abdominal, lower limb, upper limb. While if am I doing the primary survey, then after finishing that and I feel my patient is unstable، يعني مريضي بعد مو زين، انا شفت الاير واي وشفت البريثنج وشفت السيركوليشن وشيكتهن ومريضي بعده مو زين، فما اقدر اعبر للسكندري سيرفي، ما اقدر اروح اشيك الابر ليم فراكتشر، ما اقدر اروح اشيك اللور ليم انجريز. لازم شو اسوي؟ I should do a re-evaluation، ارجع اعيد البرايمري سيرفي مره ثانيه واشوف انا وين عندي missing point او وين عندي hidden injury and I not doing it. So that time I should search again and complete my primary survey another time until I reach stable patient، حتى بعدها أعبر إلى secondary survey. What is the component of secondary survey? Briefly we talking الhistory هو المهم and physical examination from head to toe، بعدين complete neurological exam، a special diagnostic and re-evaluation. History لازم يختلف عن الهيستوري اللي اخذه بالحالات الكولد كيسز، من نصعد للطابق او من نقعد بالاوت بيشنت، انا اخذ history of cold case. While if I am in an emergency trauma and I receiving a gush mortality of morbidity and injuries, I should do a shortened history. shortened history يتألف من كذا حرف اللي هن 4 إلى 5 حروف اللي هي تكون كلمة ample. شنو هي الامبل؟ الامبل هي I should know about allergies، انت عندك حساسية من شيء معين، medications انت تاخذ ادوية معينة، past illness and or pregnancy انت عندك اصابات سابقة، عندك امراض سابقة، عندك مشاكل سابقة، او are you pregnant if you are female. last meal شو وقت اكلت اخر مرة حتى اعرف اذا ادخل مريض عمليات شو راح اتوقع يصير عندي. and the events تتذكر الحادث، تتذكر شنو اللي صار، تعرف انت شنو اللي صار لك، انت انشمرت من السياره، تعرف الباص شنو بيه كان، تعرف المشاكل. and environments كانت الدنيا حاره بارده، شنو هي الاحداث اللي صارت، كنتوا بمي كنتوا بقاع، شنو اللي صار. and mechanism شنو نوع الاصابه اللي صارت، انت بسياره وانشمرت منها، انت بشارع وضربتك سياره، وانا ما انضربت السياره تتذكر شنو اللي صار immediately، انت اجوا احد شالك ظليت بالقاع. هذا الهيستوري الوحيد اللي يفيدني in multiple injured patients. We are abbreviated it in an ample. يختلف ايضا عن ال disability اللي بالبرايمري سيرفي انا اخذ الهيستوري مالتها it is an AVPU، يعني A verb A alert، V respond to verbal، P respond to painful، and U unresponsive. So we call it AVPU. While in primary secondary survey صار شوية a little bit extended، قمنا نسميه ample. الميكانيزم مثل ما موجود، اما حريق، اما حادث، اما frostbite، اما cold injury، اما water injury and what's happened. نيجي وراها الى detailed examination of each parts of the body. بالhead I should look for the external examination about the scalp، about the ears if I have otophagia، comprehensive eye and ear، about the mouth visual acuity، about the maxillary damaging if happened، about the mandibular problem، denture loss or even obvious fracture. ورا ما كملت البرايمري سيرفي. maxillofacial about bony crepitus over the bones، deformity بالhead and neck، والmal occlusion of the jaws. neck ورا الهيد اروح اباوع ايش القى soft tissue مثلا blunt versus penetrating، اكو فد obvious injury، symptoms airway obstruction. البيشنت ده ياخذ نفس وعنده سترايدر، يعني اكو عنده neck trauma blunt trauma اللي مسويت لي injury للتراكية or something. hoarseness in voice. where findings if I find crepitus hematoma or stridor or bruit. هذه لها علاقة بالنك. 4 شغلات رئيسية: crepitus in the neck, hematoma in the neck, stridor when he's speaking, and bruit. أحد يقدر يعطيني شرح بسيط لمعنى كلمة stridor؟ شنو معناها؟
دكتور، هو الهاي بيتش ساوند اللي حيصير during الانسبيريشن، وهو usually indicates انه هو upper، يعني انه بالتراكيا narrowing بالتراكيا or obstruction.
ممتاز، جيد جدا. اكو احد بعد عنده اضافه؟ So it is an upper airway obstruction. It is an abnormal breathing. ممتاز. It is an upper airway obstruction. It's a breathing with a special sounds اللي يصير due to obstruction of an airways. So it lead to some sort of an emergency due to edema and obstruction of the upper airway passages. من أسحب نفس أسحبه بصوت. ليش؟ narrowing of upper airway. In the chest, after I looking to the head and neck, I will have a looking on the chest. I should inspect, then palpate for rib fractures and emphysema, then percuss for looking for any pneumothorax or hemothorax or chylothorax or something. Then after that, auscultate, breathing sounds and heart sound. And if I find nothing, I can ask for X-rays of the chest. مثل ما بدنا نشوف هنا البيلت ساين بسبب السيت بيلت injuries and these multiple traumas. In the abdomen, after chest, I should look and inspect for abdominal injuries. Then I should percuss. After that, looking for any collection or dullness. After that, I should evaluate if I find nothing more. After that, I'm doing FAST or DPL in the primary survey. Then I do a special studies. The special studies mean I should do a abdominal CT, or I'm doing a DPL, or if I find nothing in the FAST in the primary survey, I can repeat it now in the secondary survey. Perineum, looking for contusions, hematomas, laceration, and urethral blood. All of these areas may indicate an injury to the pelvic regions. And I have certain precautions that prevent me from doing a urethral catheter. اللي هو primary survey. I will look it in the secondary survey. أحد يقدر يعطيني contraindication of a urethral catheter؟
pelvic fracture دكتور.
واحد يعني شو يطلع عندي المريض؟ ايش ابغى عليه حتى اقول اكو features of pelvic fractures؟
دكتور يكون هيماتوما في البرينيال اريا، ممكن حتى يكون بلاد يطلع من اليوريثرا او من الفاجينا اذا كانت فيميل، من الركتس، ويكون البيشنت عاده شوك لانه هو البيلفيك فراكشر يفقد كميات كبيره من الدماء دكتور.
زين excellent. هذا واحد. When there is features of pelvic fracture I cannot do urethral catheter. When there is blood over the meatus in the male and the vaginal in the female, this may indicate a urethral injury. When there is deformity of the pelvis, I can expect to have a pelvic injuries and urethral damage. But by PR examination, I may find a high riding prostate. That means I may have a urethral injury. So in these stations, and these situations, I cannot put a urethral catheter because if I have a partial injury, I will make it complete transection and it will have a serious sequelae and complication. Rectum, I should see the sphincter tone and high riding prostate. Pelvic fractures, I feel it. Rectal wall integrity and blood. The vagina, the same thing. In the pelvis, I should know about the pain on palpation, leg length discrepancy or inequality, and instability of the patient, or the patient cannot move his lower limbs, and X-ray if needed. Extremities, I should now assess for a contusion or deformity, pain and perfusion, peripheral neurovascular status, features of compartment syndrome. If I find a tense lower limb, I can expect to have a compartment of the lower or upper limb, and I should do urgent fasciotomy to get rid of any necrosis and damage of the underlying tissues. In neurologic, I see the brain, the Glasgow Coma scale, pupillary size and equality on both sides, lateralization sign, يعني واحد عنده decerebrate and decorticate, and a frequent re-evaluation is important, and prevention of secondary brain injury. من يجي secondary brain injury؟ يجي من الهايبوكسيا، يجي من الهايبرناتريميا، يجي من الaggressive and inappropriate replacement of a fluid, brain edema, and sequential brain damage. In neurologic and spinal assessment, I should do an examination of a whole spine. As we said, I should do log rolling in disability. أقلب المريض كله كقطعة واحدة، ولكن in secondary survey I should see the whole spine and examine for neurologic examination for sensation and motor and reflexes. And if I find tenderness, complete motor, and imaging studies. The pain management is very important in patient with traumas. احنا لما عرفنا انه هذا البيشنت acute abdomen وهذا المريض يحتاج يدخل عمليات، I can give him analgesia at that time. الانالجيسيا اللي نستعملها عادة بالطوارئ هي عادة opioids، يعني بيثيدين، مورفين، وعادة يكون الانجكشن مالتها IV not IM due to many causes. So I should give the patient a pain relief and waiting for his fate in the operation room. Careful monitoring is assessed and administration intravenously of analgesia. After that, if I finish all the examination and my patient needs referral because I found certain neurological deficit or urological problem or chest problem, I should send for a specialized center if I have no team. So those patients with injuries exceed institutional capabilities, I can make or think of a transfer. But I should make it when I feel that I'm doing the thing that is right and I'm referring the correct patient, and I'm not make the patient exposed to failure or hazard or death on the site. Multidisciplinary or complex injuries, I can send them. Patients with comorbidities or age extremities, I can send them. And any patient that exceed the capability of the hospital or any number that exceed the capability of the hospital. When you should transfer, as soon as you finish the primary and secondary survey and your patient is stable. So airway and ventilatory support should be present. The local facility, you should call the transfer agreement with the local resources, then either to trauma center or special facility. وخلص التعامل. هذا نفس الدايجرام about the preparation with the primary survey evaluation and adjuncts, then secondary survey and resuscitation with the adjunct, then re-evaluation, either definitive care or transfer. وشكرا جزيلا. اكو احد عنده فد ملاحظه معينه؟